Dr. Sanjeev and the learned delegates of this debate, you'll agree with me, we cannot think of managing a case of type 1 diabetes without insulin. So all of you will agree to me, the insulin and the insulin is the sole therapy for type 1 diabetes. So let us see the evidences I'll present before you in next 10 minutes. Regarding the prevalence, you know around 5 lakh children in the world are under 15 years living with type 1 diabetes, and we are adding around 78,000 children every year to the list. Only Southeast Asia contains half of them. We are burdened with 50% type 1 diabetic population below 15 years, and India contains almost 1 lakh children with type 1 diabetes. You can see after Australia, New Zealand, Bangladesh, India has 4.2 per 1 lakh population. The incidence estimated of type 1 diabetes children 0 to 14 years in 2011 by IDF. You know the natural history. The beta cells, they come down, there is genetic predisposition, environmental trigger, and there is insulitis going through the pre-diabetes and the diabetes with a lot of immunological mechanism which are not going into detail. The purpose of showing you this slide is the cell-mediated and the humoral immunity with a lot of antibodies at peripheral circulation, at peripancreatic lymph nodes as well as pancreas cause gradual destruction of the beta cell leading to insulinopenia, and this beta cell population gradually fluctuating and almost getting nil at the end. So in different phases, appearance of autoantibodies, clinical onsets, and completely C-peptide negative patients, the beta cell falls to touch almost nil. So in a patient who doesn't have any beta cell reserve, can you think of managing the patient with any drug except insulin? That's the question I'll ask to my opponent, Dr. Shah. You can see the achieving blood glucose target is a daily challenge for people with type 1 diabetes. Lack of improvement in glycemic control despite increased intensity of insulin treatment, and with 4 injections with a multiple dose insulin regimen in 92, the control was only 27.8%, which has increased to 74.6%, but the A1C levels remains almost same in both this assessment in German study of more than 18,000 patients. So day-to-day variability in blood glucose in type 1 diabetes as assessed by continuous glucose monitoring is horrible, and when we face a lot of challenge in type 2 diabetes, you think of children, small children with so many issues like unplanned snacks, they can take food at any time, uncertain motion, milk quantity, they can take more, they can take less, long breakfast lunch gap, they can move around, playful, and the risk of hypoglycemia in the school who are not really conscious about their food, and managing them creates a lot of problem, the unique problem in children in getting a good control. And this is the first person in the world to receive insulin injection, Mr. Leonard Thompson, who was detected type 1 diabetes and received the insulin at the age of 14 years and went on to live 13 more years taking dose of insulin, and since then insulin is the therapy in type 1 diabetes, and insulin is an oxygen for survival of type 1 diabetes, in which all of you will agree to me. It's not only a therapy necessary for achieving glycemic controls in a patient absolutely deficient in insulin with complete islet cell destruction. We must give exogenous insulin to sustain life, to prevent diabetic ketoacidosis, to achieve glycemic control, and finally to prevent the long-term complications, both microvascular and macrovascular. All of you know about the landmark DCCT trial, which in type 1 diabetes demonstrated the prevention of microvascular complications. And of late, the diabetes intervention, the epidemiology of diabetes intervention and complication, the EDIC trial has come, telling the role of insulin in intensive glycemic control and reduction of macrovascular complications. So in a diabetic patient, to achieve a long-term control and a complication-free life, microvascular as well as macrovascular, the DCCT and EDIC, both landmark trials, have proved that the intensive control with insulin is mandatory. And you can see the poor glycemic control among youth with diabetes is a big challenge to us, and half of our patients, the American and the Indian patients, almost more than 50% don't have a very good control, and A1C is more than 9.5%, as well as the people from other areas, the African, the Hispanic, the Asian and non-Hispanic also have a poor control. And you can see the A1C less than 7 is only in this smaller population, and most of them have a more than 7 A1C in type 1 diabetes, and suboptimal glycemic control is very common, leading to complications. So what 2015 ADA guidelines tell about evidence-based medicine in managing type 1 diabetes? In pharmacological therapy for type 1, the most people with type 1 diabetes should be treated with multiple dose insulin, the MDI injections, 3 to 4 injections per day of basal and prandial insulin, or continuous subcutaneous insulin infusion with evidence level A. I am not going to the details of the insulin therapy because of the paucity of the time. I think my learned audience know about the MDI or CSII, both the regimens. And most people with type 1 diabetes should use insulin analogues. They have also approved the insulin analogues to reduce the hypoglycemia risk, because it's a lifelong therapy with a lot of complications and a very challenging in management. So analogues they have approved. And the most people with type 1 diabetes should be educated in how to match prandial insulin dose to carbohydrate intake, pre-meal blood glucose and anticipated activity. It's not that a fixed pattern can fit them. According to their activity, according to their food, according to their need, they should be well trained in titrating the dose, and the only recommended therapy is insulin, that in multiple dose, and a preferred way is the insulin pump or the artificial pancreas to avoid hypoglycemic excursions. And let us see the severe hypoglycemia can, if you consider, definitely the pump will have an advantage over the multiple doses. So in 2012 meta-analysis, most of the studies in children with type 2 diabetes and adults with type 2 diabetes, meta-analysis supports the pump in comparison to the multiple dose insulin. And let us see few things about Dr. Shah's army, the molecules, the other drugs like Metformin, DPP4 inhibitor, amylin analog, GLP-1 analogs and SGLT2 inhibitors. The drugs which so-called agents has been discussed and approved in patients of type 1 diabetes. A car cannot move unless you have an engine. This can be an accessory. This can be like a mat, it can be like a wheel cover, can be like a belt, but they cannot be engine. And in our patients who are already burdened with disease, with complications, can we give a cost burden at the same time with risk of side effects and inefficacy of these agents, and can we pull on their whole life with these agents? Let us see what they promise us. Metformin, only 5 trials available in type 1 diabetes. They have a promise of decreasing A1C of only 0.11, and the insulin dose requirement comes down by 6.6 units per day. That's all. But they have no advantage in A1C as well as prevention of macrovascular or microvascular complications. Glitazones, only 0.22% reduction in HbA1c. They can cause increased edema, and the C-peptide decline can be faster in the patient of diabetes. The Prevalent TIDM, the amylin analog, is not available in India, you know. This is again an injectable medicine, another addition of 3 injections, and 20% patient they don't tolerate, and this study tells only reduction of A1C by 0.3% and weight loss of 1.8 kg with increased risk of hypoglycemia. GLP-1 analog is of course useful in weight reduction, that's around 2.3 kilos in our patients, but it suppresses the postprandial glucagon, and patients studied C-peptide positive and negative, and 2.5 unit per day can decrease in positive patients, and 4.5 unit per day insulin requirement can decrease in C-peptide negative patients. But it's again an injectable drug with a lot of side effects, GI intolerance, and the cost, which all of you know. DPP-4 inhibitor, our very close drug in type 2, and all the studies in type 1 shows A1C reduction of only 0.27 with only 13.8% reduction in total daily insulin dose requirement and no difference in weight. So this is all as a additive, as a decorative to the insulin, and they don't have a role independently without the insulin. And the SGLT2, which you are listening the noise nowadays, is a unique mechanism of insulin independent glucose reduction. The efficacy so as to add into insulin only 5.5% reduction with minimal risk of hypoglycemia, but they have increased risk of urination, urinary tract infection, thrust, and if you decrease the insulin dose much, there are chances of precipitation of ketoacidosis because of lack of insulin. So finally, I'll end with this patient, this 87-year lady from New Zealand, who was detected type 1 at the age of 6 years. For the last 79 years, she is on insulin. She was predicted a shorter life by her doctors, but though she lost her sister at the age of 16 years, who was a type 1 diabetic, she has given birth to 4 children, two are twin among them. She has 8 grandchildren and 7 great-grandchildren, and another issue is on the line to come. So only insulin has made her survive so long, and such a long story in many type 1 diabetic adult patients you'll get that has become possible only with a single drug, that is insulin. So to summarize, my moderator, my opponent and learned audience, insulin remains the only best choice to treat type 1 diabetes. Non-insulin therapies have physiological rationale, but with limited net clinical benefit considering additional efficacy, safety and cost of these treatments. They can be used in addition to the insulin with additional risk of side effects, additional cost and also the inefficacy in our patients. Only near future, the paradigm change is artificial pancreas with insulin in type 1 diabetes or continuous subcutaneous insulin infusion, which promises to ensure better in our patient. Thank you for the attention.